Enterococcus species, and commonly bloodstream and urinary isolates is what we often see. Now, these add to the morbidity because there is prolonged antimicrobial causes. It prolongs your patient's ICU stay, ultimately hospital stay, in, increased costs. So stewardship is what matters because it would prevent overuse of vancomycin and linezolid-like drugs. And cephalosporin also exposes to exposure selects enterococci. So infection prevention and control measures need to be in place to prevent the MRSA and VRE from occurring. The gram-positive organisms that we often see are staph, Staphylococcus, Streptococci, Enterococci, and other gram-positive bacilli like Clostridium, Listeria, Corynebacterium. So, what are the resistance mechanisms by which the gram-positive bacteria actually develop resistance? So, for methicillin-resistant Staph aureus, this is aminoglycoside modifying enzymes. So, drugs like gentamicin and streptomycin, the synergy gets lost. So then, in patients with E. faecalis infective endocarditis, you can use ampicillin and ceftriaxone. Then vancomycin resistance enterococcus. This occurs because of the Van resistance, which alters the DLA target. So what happens? Then again, your vancomycin and teicoplanin for this enterococcus becomes ineffective. So your drug of choices become linezolid, daptomycin, depending upon the site of infection. So to keep these in mind whenever you're dealing with a patient who you started on treatment is not getting better, because there is a possibility of resistance mechanisms as well. Now, where does gram-positive coverage matter? A patient who presents with purulent skin soft tissue infections, abscesses, there are lines and devices, prostheses in situ which seem like the possible cause of infection. A patient who got better after the initial influenza infection and comes back with a cavitating pneumonia. You're growing gram-positive cocci in blood culture, and then of course the endocarditis or the embolic phenomena patients. Do not use gram-positive coverage alone for patient who is in septic shock with an unknown source, just because you want to give a broad spectrum coverage, which is very commonly done and a lot in the Indian ICUs. Don't do that. A patient with ventilator-associated pneumonia or intra-abdominal infections where MDR gram-negatives are common, and patient with an aspiration pneumonia without MRSA risk, just don't add gram-positive cover. You have a patient who has a positive urine culture with a gram-positive blood, but there is no way possible that the patient has a UTI. Do not treat the patient just because there is a report that says positive. Rule out colonization. Fever in ICU without clinical localization. It could be a non-infective fever, so you need to know when to actually appropriately add gram-positive cover. So let us look at the drugs that we commonly use and their specific mechanisms and site of action. So we have beta-lactams, that is penicillin, cloaxacillin, cefazolin, ceftriaxone, glycopeptides, vancomycin, teicoplanin, dalbavancin, and oritavancin. Then oxazolin dinones, that is linezolid and tetrazolid, lipopeptides, daptomycin, then tetracyclines like doxy and minocycline, and trimethoprim sulfamethoxazole. So, vancomycin. A few aspects of vancomycin that I would like to tell. It is a drug of choice for serious MRSA infection. Given in critically ill patients, you have to reassess the doses and monitor the patient's changing renal function, monitor dosing, and give it a lot of precautions in patients with AKI and CKD if you really have to. Look at the dosing in patients on ECMO, CRRT, obese, burns because of ARC. We talked about this in the previous session. Then, when you're using this with any other concomitant nephrotoxic drugs, because these things you have to keep in mind before you're choosing vancomycin as your drug for MRSA infection. Then, in suspected serious MRSA infection, the dose of vancomycin loading is 20 to 25 mg per kg, the actual body weight. Maintenance is at 15 to 20 mg per kg, IV 8 to 12 hourly initially, and then if it's possible, you can therapeutic drug monitoring, or if you can do the AUC guided monitoring, that is preferred. It's available. The target is to keep the AUC 24 over MIC between 400 to 600. You want to avoid toxicity because one, we already know it is a nephrotoxic drug. Give it with precaution with other drugs in combination with drugs like piperacillin, tazobactam. Unnecessarily prolong the duration of the course. For how long do you want to give? And if you get culture reports and it shows MSSA, then you switch to cefazolin or fluoxetine. Do not just continue vancomycin because it works. Then the second drug that we often use is the teicoplanin. The dose of teicoplanin for routine skin and soft tissue is 6 mg per kg BD for 3 doses, and then followed by 6 mg per kg once daily. Loading is the most important aspect of this drug, which I want to emphasize on today, because generally you would see people writing 400 mg IV once daily or 600 mg IV once daily. Don't forget that in severe infections like sepsis, the bacteremia, or even deep high inocular infections or osteomyelitis, the dose is 12 mg per kg PD for 3 doses in severe infections and sepsis, pneumonias, and for deep-seated infections, it's up to 5 doses PD, followed by 12 mg per kg once daily. Do not forget to load teicoplanin. Don't just write OD dose. It is very important because it is actually often the failure of giving loading dose, not the infection that you're treating, which is not getting better. Then linezolid, which we use as pulmonologists as well, we use it a lot for MRSA because it has excellent lung penetration, and it is the recommended option for MRSA half-pack as well. You have to monitor for toxicity in these patients. So remember that a patient who has been put on linezolid and begins to have thrombocytopenia the very next day, it is not because of linezolid. It takes a little while for the linezolid to actually cause thrombocytopenia. Usually about 5 to 7 days minimum, and it can also cause anemia. When given with SSRIs or MAO inhibitors or tramadol, it can cause the serotonin toxicity risk. Avoid prolonged unmonitored courses because it can lead to optic neuritis, peripheral neuropathy, and even there's a risk of lactic acidosis. And it is a bacteriostatic drug, so you have to consider the severity and the source of infection before actually choosing it as a drug of choice. In high inoculum deep-seated infections, you might consider daptomycin instead of linezolid. And because the oral bioavailability of this drug is efficacious and equally good, you can switch to oral when you're stepping down your patient from IV treatment. The next drug that we're going to look at is daptomycin, which is a great bactericidal drug, but it is site-specific, used in MRSA bacteremia, right-sided endocarditis, catheter-related bloodstream infection, and VRE bacteremia. We have talked enough about this, and I cannot not emphasize again today. It is not a good drug for lung pneumonia because it is inactivated by the pulmonary surfactant. Do not use it in patients with pneumonia. The dose is for MRSA bloodstream infection 8 to 10 mg, and for VRE epithelium it requires a higher dose of almost 8 to 12 mg per kg. Then you have to monitor baseline and weekly the CPK values, and also with patients on statin, watch for renal dysfunction, patient developing myalgia, and especially monitor when the patient is on prolonged therapy. Ceftaroline is the beta-lactam which has activity against MRSA. So it is useful in MRSA, skin soft tissue infections, MRSA cap. It has been used off-label as a salvage combination for persistent MRSA bacteremia. It has good beta-lactam killing, MRSA penicillin protein binding 2A activity, and a good tissue penetration. It is not a drug for VRE, so don't mix it. Just because it has activity against MRSA, and in prolonged use, you should monitor for neutropenia. Now you've understood the basic bugs and you've understood the basic drugs that we use for patients with gram-positive infections. If you combine them wrongly, then you will not be able to achieve the desired outcome and your patient will not get better, worsen only. So, I just told you daptomycin for pneumonia cannot be given because it's inactivated by the lung surfactant. Vancomycin for MSSA when beta-lactam is possible because it has inferior outcomes. So switch your patient to cefazolin, cloxacillin, nafacillin or oxacillin, which are the MSSA drugs. Linezolid for simple cystitis. Only because your report is showing vancomycin resistant. Don't do that. It could be a colonizer. Check the symptoms. Look at the patient's. Is it possible that this patient has a VRE UTI? Only then think of. Otherwise, not linezolid, but think of the drug. Otherwise, it could just be a colonizer. Then cephalosporin alone for enterococcus. It has intrinsic poor activity. So give ampicillin for susceptible, and if it's VRE, then you treat accordingly. If you give rifampicin in uncontrolled bacteremia, it has a risk of developing rapid resistance. So do not institute just because you want to give combination, and it should be used with great caution when you're giving it as a combination in selected patients with prosthetic infection. Then source control. I think we've been talking about this in all the lectures that we've had before, that just getting your cultures, starting your antibiotics is not enough. You have to drain that abscess, that empyema, treat that septic arthritis, remove that infected central venous catheter, or replace it, debride that necrotizing fasciitis wound. If needed, repeat imaging. If your patient is having persistent fever and you have started on adequate therapy. So, just don't blame the drug. You have to check the source, and unless you achieve source control, you will not get the desired outcome. Now, since I was talking about the bugs, let's look at the bugs a little more in detail, starting with Staphylococcus aureus. So, a Staph aureus infection in blood is not a contaminant unless you have a very strong reason. So, never ignore it. It can cause metastatic infection, so you have to be sure when you are treating a blood staph. Source control is mandatory. You have to remove that infected source. Follow-up blood cultures are a part of treatment. They are not optional. Unless you get a negative culture, you must repeat them every 48 to 72 hours. And MSSA must be treated with an anti-staphylococcal beta-lactam whenever possible. So there is an entity called MRSA cap. What is it? What would you suspect? What would be the clinical triggers? So a patient who comes with a community-acquired pneumonia is very sick, requiring ICU admission, develops shock, comes in ARDS, has ARDS. A patient who was doing well after his initial influenza infection and now comes with a large consolidation. A patient having necrotizing, cavitating, or infiltrates or maybe empyema, but it has to be correlated. Neutropenic patients, a patient with erythematous rash or a concomitant skin soft tissue infection, and those who have known MRSA colonization or close contacts with MRSA carriers. Then there are certain environmental clues as well. History of IV drug use, recurrent boils or nasal colonization, recurrent hospitalization. Those who live in close contact settings like prisons or army barracks, an immunocompromised host can have any infection, so this can also be a possibility. Then there is skin and soft tissue infection with methicillin-resistant Staph aureus. So, practical algorithm to approach it would be that if there is an abscess, you do incision and drainage. If it is mild, add an oral drug. If it's a systemic infection, add MRSA cover. Necrotizing infection, you have to operate the patient. And then once you've achieved adequate control, de-escalate once the patient is showing response and you've got your cultures as well. So for MRSA skin and soft tissue infections, for a simple abscess after the initial incision and drainage, you can give trimethoprim, sulfamethoxazole, doxycycline, and clindamycin if there is a systemic risk. For cellulitis, which is non-purulent, beta-lactam is usually inadequate cover. For purulent cellulitis, trimethoprim, sulfamethoxazole, doxycycline, trimmed or IV vancomycin if there is severe infection. Necrotizing infection, have to operate to not delay the debridement and add vancomycin or linezolid plus a broad gram-negative and an anaerobic cover initially. You may de-escalate later, but initially you must cover all. A patient with severe diabetic foot, again MRSA with gram-negative anaerobic cover depending on the severity, but you have to image, you have to debride that diabetic foot and take a vascular opinion early because sometimes these patients require amputation. So he's just talking about a necrotizing soft tissue infection. How would a patient present? There would be pain out of proportion, rapid progression, shock, necrosis, hepatitis. Commonly caused by group-based streptococci, staph aureus, MRSA, Clostridia, mixed aerobes and anaerobes. And treatment, like I said, you cannot delay surgery. It has to be urgent and broad cover should be given along with toxic suppression. So what do you do in patients when you are dealing with MRSA bacteria in the first 24 hours? You start active IV therapy with vancomycin if it is possible to do AC guided, I think that is the best, or daptomycin. If bacteremia or right-sided infective endocarditis phenotype, repeat blood cultures every 24 to 48 hours. If not, then at least 40 to 72 hours because sometimes there are certain constraints. Remove the infected source, drain all the collections. Echo transthoracic should be done in all patients, and transesophageal when there is higher risk, persistent bacteremia, prostatic valves, devices in situ, and you don't know the source, and actively search for metastatic foci. So how do you differentiate the Staphylococcus aureus bacteremia? It can be uh, complicated and uncomplicated. So an uncomplicated Staph aureus bacteremia would have negative follow-up cultures at 2 to 4 days. It may have fever, it might settle very early, within 72 hours. They won't have any risk factors of endocarditis, any prosthesis in situ, or any possibility of metastatic infection. A complicated Staph aureus bacteremia would have persistent symptoms, persistence of fever, persistent positive cultures, confirmed or possible infective endocarditis. There is going to be a valve, device, or joint in situ which needs review, could be the source. And then, of course, metastatic infection. So you have to have bone joint evaluation, epidural abscess, or emboli. This is the basic difference between the Staphylococcus aureus bacteremia, uncomplicated and complicated. Difficulty to swallow. Now, the duration of treatment. So, just told you about the MRSA bacteremia. So, for a non-complicated staph bacteremia, 14 days from the first negative culture. For complicated, 4 to 6 weeks. Right-sided infective endocarditis, 4 to 6 weeks. Left-sided infective endocarditis or prostatic valve, usually more than 6 weeks. Osteomyelitis or epidural abscess, at least minimum 6 or more weeks. And of course, for these collections and abscesses, you need to have drainage and decompression. It has to be done simultaneously. You have to stabilize your patient and do it. What could be the reason if your patient still continues to have persistent MRSA bacteremia? It can be because of an undrained abscess, infected thrombus, there is a retained line or device. So unless you actively rule out the sources and achieve adequate control, you will not get the desired outcome. Your patient will be persistently symptomatic. You repeat cultures, look at the MIC confirmation, do therapeutic drug monitoring, check for toxicity if needed, and salvage options if, in spite of achieving everything and doing a good source control, you can consider a high dose daptomycin if there is no pneumonia source, and ceftaroline based combinations in selected persistent MRSA plus infection patients. The second bug that we see is the Enterococcus and biliary. So we know it is a facultative anaerobe and it is a commensal in GIT. It survives on surfaces, bed rails, doorknobs, and we see clinical syndromes, UTI, bloodstream infection, infective endocarditis, abdominal infection, CNS, skin and soft tissue. E. faecalis and E. faecium cause most of the diseases. For faecalis, ampicillin is often susceptible, and for E. faecium, it's mostly resistant. It's a VRE, and you have to accordingly decide for therapy. And in that, so the basic difference between the common enterococcus, that is faecalis and faecium. Faecalis you would see commonly in patients with UTI, infective endocarditis, intra-abdominal infection. Faecium is often healthcare associated bloodstream infection, and there is vancomycin resistance. Ampicillin is susceptible, and therapy is always ampicillin based. And if there is E. faecalis and endocarditis, ampicillin plus ceftriaxone become your drug of choice. For E. faecium, it is often resistant to ampicillin as well as vancomycin is even more common. So therapy is with linezolid and daptomycin if you're dealing with VRE. And for endocarditis, it has to actually, you have to take your ID specialist, you have to discuss with the microbiologist and decide about the line of management. So VRE epidemiology and impact in India. It has been seen that the prevalence is low, but it has risen from 4.8 in the 2000s. In 2020, it almost become 14.1%. So what are the mechanisms by which enterococcus develops this vancomycin resistance? So there's VAN A resistance, which is high level of vancomycin resistance, and in VAN A, it is often even resistant to teicoplanin. So you use linezolid or daptomycin if you're actually dealing with true infection. And in VAN B, it is vancomycin resistance, but it may be sensitive to teicoplanin. But do not rely on glycopeptide. You just cannot start giving teicoplanin. This has to be correlated, even clinically. This is anti-inflammatory. Now, in cases of VRE, whether you're dealing with a colonizer or a true infection, how would you differentiate? What would you actually look at? So, a colonization could be a patient with a rectal screen positive, no clinical syndrome, a urine VRE with no urinary symptoms. The patient has not ever undergone any urological procedure, and suddenly, you've got a VRE on his urine sample, the culture. A drain or respiratory culture, and there is no presence of any obvious respiratory symptoms or any um, consolidation or any positive findings on your radiology. Then mixed intra-abdominal culture after source control and clinical improvement, it's usually colonizers that you're dealing with. So, and when is it actually a true infection? When there is bacteremia, when there is an endocarditis or an infective device, symptomatic UTI, pyelonephritis with VRE, intra-abdominal sepsis with high risk of VRE, persistent fever or sepsis, and you're actually getting VRE from sterile sites. So this is where you have to treat the VRE infection seriously. So just to summarize, how would you approach a patient with VRE bacteremia? First, understand what you're dealing with, E. faecium or faecalis, which would come on your cultures. Check the MIC, check what drug, whether you can give AMPI, Vancol, linezolid or daptomycin. Where is the source? Is it your line? Is it abdomen? Is it urine? Is there any persistent bacteremia? If yes, you need to repeat blood cultures until clearance. Can you remove that line? Have you removed that line? Have you drained the source? And look at your host. Are you dealing with a neutropenic or a transplant patient or a patient who's critically ill in septic shock? Then your threshold has to be even more aggressive in such patients. A word about VRE bacteremia and linezolid and daptomycin. So we all know that linezolid is a bacteriostatic drug. Dose is 600 twice daily. It is the best drug for pneumonias and great for step down. We just told you about the toxicity profile, so you need to monitor accordingly. Daptomycin is a bactericidal, high dose of 10 to 12 mg per kg for VRE, and E. faecium bloodstream infection. You need to monitor the CPK levels, look for myopathy, and monitor these patients, especially if you're giving them prolonged course. It's not a drug for pneumonia. So do not use it as a drug in patients with pneumonia. Then patients with VRE UTI. So if the patient has asymptomatic bacteria, please don't treat. Don't just treat cultures, which is the habit. You saw the reporting, you start adding gram-positive cover. Don't do that. For lower cystitis, nitrofurantoin or fosfomycin if your bug is susceptible and renal function allows. For pyelonephritis or urosepsis, linezolid or daptomycin. If susceptible, catheter associated, replace that catheter first. Sometimes source control is enough. You don't always need to add antibiotic cover. And if you're growing mixed flora in the urine, then send repeat sample. If it is a long-standing catheter, remove the sample. Sometimes achieving source control is usually enough. You don't need to add antibiotics. Then for streptococci, there are certain common syndromes and drugs like group A streptococci can cause cellulitis, necrotizing fasciitis, toxic shock. So drug of choice is penicillin, ceftriaxone, and you add clindamycin for toxin disease. Group B strep, bacteremia, diabetic foot, peripartum disease. Again, penicillin, ceftriaxone, vancomycin only if the patient is allergic to penicillin. Strep viridans, endocarditis, so penicillin, ceftriaxone, depending upon the MIC. For streptococcus pneumonia, it can cause meningitis, bacteremia, pneumonia. So it would depend upon the site of infection, and accordingly you choose between ceftriaxone and penicillin, and of course based on the susceptibility. Then, what are the common mistakes you should avoid? You can keep continuing vancomycin. I just told you, switch to MSSA cover once you know that it is MSSA and you're not dealing with MRSA. Treating a VRE colonizer. You need to be able to differentiate between colonization and true infection. Using daptomycin for pneumonia. No repeat cultures in, not sending repeat cultures in staph aureus bacteremia. You need to repeat until clear. And if you are not getting a clearing of your cultures, then you need to actively start searching for metastatic foci and escalating without source control. You have to drain, you have to remove that line, you have to drain the abscess and do imaging, repeat imaging if needed. So treat the infection, not the culture report. You have to correlate your bug drug insight, which is the simplest way to approach any infection. MRSA coverage should be selective, not reflexive. Staph aureus bacteremia always needs repeat cultures. Echoes and metastatic search, do not dismiss it. MSSA needs beta-lactam therapy. Daptomycin is not for pneumonia. Linezolid is useful for MRSA pneumonia and VRE, but it has to be monitored for its toxicity. VRE colonization needs infection prevention and control practices and not antibiotics alone. It's majorly the infection prevention and control practices. E. faecalis and faecium are different clinical problems. You need to be able to differentiate, understand the enterococcus you're dealing with, and accordingly choose your antibiotics. Persistent infection means searching the source before just blaming the antibiotic not working or changing your antibiotics quickly just because your patient is not getting better. Thank you.
Thank you, Dr. Akansha, for giving a wonderful presentation as always. And I think all through our 10 modules, we have been saying that we overtreat colonizers. So I think it is important, unless there is a syndrome, unless there are symptoms, we need not treat these infections. So we begin with today's talk. We approach not the gram-negative infections. As I told you, in India, in particular in ICUs, we have more of gram negatives and very less of gram positive. And we do get gram positive. It is not that majority is gram negative. So that's why we've kept about 4 talks on 4 modules on gram negative infection, going into the depth of everything. So we begin with today approach to the gram negative infections. So I have a great pleasure in introducing Dr. George NATO George Mundenden. He's a specialist in ID and internal medicine. Very nice gentleman, assistant professor and head of department, Government Medical College, Kottayam. He's got a 14 plus year in government and private healthcare, extensive clinical and academic experience in infectious disease. He's an excellent teacher. He's former consultant in the infectious disease and antibody stewardship lead in Rajgiri Hospital, Aluva. His area of interest, of course, is an ID, internal medicine, antibiotic stewardship program, and complex infection care. So he's going to talk on the first talk, that is the basics. He's getting us into the how to approach the gram-negative infection. Over to you, Dr. Nick.
So thanks, Dr. Chawla, for the kind introduction and for inviting me for these sessions on gram-negative infections. So is my slides visible? Is it okay?
Yes.
Yeah. So I'll just put it in slideshow mode. Yeah. So I hope it is visible, right? Okay. Yeah. So let me start. So the topic given to me in the next quite a difficult task because there is a huge lot of lectures following on each type of gram-negative infection. So I, as much as possible, I will try to avoid an overlap in my session. So just for an introduction, we will know that multi-drug resistance is definition-wise is antimicrobial resistance shown by species of microorganism as acute non-susceptibility to at least one agent in 3 or more categories. So MDR is resistance to one agent in 3 or more categories, whereas XDR is their susceptibility to only one or less than 2 categories, and pan-drug resistance is non-susceptibility to all agents in all antimicrobial categories. But definition, even though the definitions are like this, these things are quite technical. So yes, coming to our topic proper, so we need to deal with a lot of gram-negative syndromes like pneumonia, bloodstream infections, urinary tract infections, skin soft tissue infections, intra-abdominal infections, and meningitis. And we have a lot of culprit bacteria ranging from Acinetobacter, Klebsiella, E. coli, Pseudomonas, Chenotrophomonas, Burkholderia, and Melioidosis, that's Burkholderia pseudomallei. So if you come to the WHO critical pathogens, so they include carbapenem-resistant Acinetobacter, third generation, that is extended spectrum beta-lactamase Enterobacteriaceae, as well as carbapenem resistant Enterobacteria. So these are the critical pathogens, whereas our Pseudomonas, Shigella, Salmonella, all these comes in high risk. Yeah. So coming to our approach, so just before going into the treatment, always we need to care about diagnostic as well as therapeutic stewardship. So regarding diagnostic stewardship, you have to send the appropriate cultures. So these things have been dealt with in the gram-positive spectrum also. And you have to differentiate a colonizer from infection. You need to know to interpret some PCR panels. And procalcitonin is an investigation that's being used widely. So the problem is that even though it is seen, high procalcitonin levels are usually seen in gram-negative infections, it should not be taken as something to start treatment for any kind of gram-negative infection. However, procalcitonin, there is some evidence that's available that it can get de-escalation of our therapy. Wherever needed, you have to give loading dose of antibiotic and do the appropriate renal hepatic dose adjustment, as well as, if possible, you can switch from IV to oral therapy. We'll deal with a few cases. I'm not going to the treatment part of any of these cases. So just seeing this scenario, a 55-year-old male diabetic who has fever, flank pain, dysuria for 5 days, and he's in shock. And the blood and urine culture is showing Klebsiella pneumonia, which is resistant to ceftriaxone and sensitive to piperacillin tazobactam as well as meropenem. I'm not going to the treatment option. What I'm going to highlight is that the patient is having comorbidity as well as the patient is in shock. So while dealing as an approach to gram-negative infection, you need to see what are the comorbidities the patient is dealing with, because there are a few risk factors that could predict a patient for acquiring drug-resistant gram-negative bacteria, which involves prior antimicrobial use within the past 90 days, recent hospitalization within 90 days, resistance in long-term care facilities, septic shock that in our patient the BP was 80/60, prolonged incubation, long ICU stay. If this patient has been colonized with a multi-drug resistant gram-negative organism, bed-bound patient, post-hematologic malignancies, post-transplant, whether it is solid organ or hematopoietic stem cell transplant. So all these place the patient at risk of multi-drug resistant gram-negative infection. So for the patient coming in front of you, you need to be aware. So even if there is a bacteria isolated, there is a possibility that they might be multi-drug resistant. Coming back to the same scenario, so next we will deal with the culture part. So blood culture and urine culture has been sent in our case. And so what are the common diagnostic challenges that we face in gram-negative bacteria while approaching the case? So we do have very long time for culture, for growth in the culture. And even though it's challenging to interpret biofire report or multiplex PCR report whatsoever in the context of a clinical scenario. Biomarker wise, procalcitonin, CRP. So if you go into the literature, nothing is hard and fast as a good biomarker, but maybe these biomarkers can be used as method to de-escalate your treatment. And nowadays we do have newer things like sequencing, identifying resistance mutations, etc. for approaching the case, which I will come to. And before going into the investigation part, let me just see. So after that, you have to see that the case is resistant to ceftriaxone, whereas it is sensitive to Bacillus intestobacter meropenem. And what are the options? So before dealing with any gram-negative infection, so this is an ESBL, and I guess Dr. Vishak will be dealing with this in detail. So you need to know about few of the challenges that we could face with respect to drug resistance, including ESBL, AMC, carbapenem-resistant Enterobacteriaceae, BTS pseudomonas, as well as carbapenem-resistant Acinetobacter. So many times, if you are not into the details of these kind of resistance mechanism, many times it will be challenging for understanding, for interpreting biofire or multiplex PCR report, because they do give a lot of these resistance mechanism. So in a nutshell, what you need to know, take home will be, if it is a CTXM, you just consider that the ceftriaxone will be resistant. If you are getting an NDM, consider that carbapenems are resistant. OXA48, KPC, all these resistance mutation are for carbapenem resistant. But all these are beta-lactamase related things. And there are other resistance mechanism also. So it is always better, from my point of view, I would say, it would be always better to loop in an ID physician for interpreting your biofire kind of reports. So, one thing that you need to be careful about is this concept of intrinsic resistance. So, whenever any patient is infected with Pseudomonas aeruginosa, so it is intrinsically resistant to the following antibiotic, that is ceftriaxone, ertapenem, tigecycline, and cotrimoxazole. So there is no point in putting a patient where the lab is telling, okay, we are having Pseudomonas and the blood culture is growing Pseudomonas. There is no point in putting the patient on ceftriaxone. And what is more important is considering ertapenem. So what the take-home message would be that meropenem is not equal to ertapenem, not equal to imipenem. So with respect to Pseudomonas, all three are three different drugs, of which ertapenem does not work at all. Whereas imipenem works, meropenem works. Maybe if you ask me which is better, maybe for Pseudomonas, imipenem might be having a slighter edge. Tigecycline is another antibiotic that never works in Pseudomonas. Similar with the case of cotrimoxazole. Klebsiella pneumoniae, a very common bacteria that you encounter. Klebsiella pneumoniae is intrinsically resistant to amoxicillin. However, if you are adding clavulanate, there's a possibility that 20 to 30% chance that might work. So amoxicillin is Klebsiella pneumoniae is intrinsically resistant to amoxicillin. Burkholderia, if you are isolating, there is no role for colistin. Similar with the case of Serratia marcescens, which is intrinsically resistant to colistin. Another usual suspect in our clinical scenario, that is Acinetobacter, is intrinsically resistant to Astrona. So just keep this table in mind regarding the intrinsic resistance, because this might, if you are unaware of this might pose problems with your clinical management. Coming to how to choose the antibiotic. So whenever you are choosing an antibiotic for a gram-negative infection, always consider the site of infection. I will come to this in detail. And see for the antibiotic concentration at the site, just like it was discussed regarding daptomycin, not to be used in pneumonia. Similarly, tigecycline is something that has a very high volume of distribution. You just put into the blood, it will distribute into all the tissues. So there is no point in giving tigecycline for a bacteremia or bloodstream infection. Always apply the principles of antibiotic stewardship. Use a narrow spectrum antibiotic that is possible. See for risk factors which I have enumerated earlier. And think about drug toxicities. Ask for history of drug allergy and see whether the patient is in any special situation like pregnancy. So just like the daptomycin case in gram positives, in gram negatives also we do have some issues. So polymyxin B is not something that can be used in urinary tract infection, whereas you can use colistin. Tigecycline, I already mentioned, is not a good drug in bloodstream infection, and even the FDA has given a black box warning for tigecycline in pneumonia case also. So these are two indications where you should not use tigecycline. However, it is an excellent drug in skin and soft tissue infection as well as intra-abdominal infection. Regarding colistin, polymyxin, I am sure you might be using a lot of colistin and polymyxin in your day-to-day practice for pneumonia cases. If you ask me which is better, I would say that penetration-wise, both are poor in lungs. If you look at the ELF concentration, both will be poor, and maybe owing to the lesser adverse effect, lesser risk of nephrotoxicity, polymyxin hold a slight edge if you are giving in case of pneumonia. Eravacycline, another tetracycline group antibiotic, is a poor one in urinary tract infection. So we were dealing with the risk factors of acquiring multi-drug resistance. So regarding the cultures. So now coming to another scenario. So similar scenario, but this time the bacteria, the patient is not in shock, but the bacteria is Enterobacter cloacae. And so this is if you are seeing this kind of peculiar organism, always you need to either involve an eye division or you need to look up regarding the sensitivity as well as you need to know the theory part. So this is an AMC which Dr. Shek might be dealing. So I am coming back to the urinary tract infection. Asymptomatic bacteriuria. So if you are taking syndrome wise and approaching gram-negative infection, the first one if you will take will be urinary tract infection. Approaching UTI, asymptomatic bacteriuria, the rules remain similar as was discussed earlier, treat pregnancy and planned urologic procedures. But what is more important is you need to know which antibiotic does not work in urinary tract infection. So polymyxin B, if your culture report is showing that it is only sensitive to colistin, use colistin, don't use polymyxin. Similarly, don't use tetracycline. Don't use tetracycline group antibiotic because that again have a poor penetration and always search for another agent. Plasmomycin, a newer antibiotic which is good for E. coli and Klebsiella, that works really well in urinary tract infection. And if the gram-negative bacteria is isolated from a catheterized sample, so first of all you see whether it is just a catheter colonizer. You correlate clinically only if the symptoms you are not getting any other cause or your new symptoms of the patient. do consider treating this catheter-associated infection. So these are some certain points that you need to take care while dealing urinary tract infection with GN. So coming to our next scenario, here we do have a patient with stroke who developed a new onset breathlessness. Of course, we do know there might be a lot of cause of breathlessness in a bedridden patient. It might be pulmonary edema, it might be a pulmonary embolism, it might be a new onset infection, or it might be ketoacidosis, a lot of causes. So anyway, since the patient it was a brainstem stroke, bronchoalveolar lavage was done and the sample was sent for biofire testing. So biofire is, in other words, a multiplex PCR where you get a lot of organism, where the panel involves a lot of organism, and now our biofire came back as Klebsiella pneumonia 10^6, and now they have given all the resistance mechanism in the world. That is, NDM is present, OXA is present, CTXM is present. So how do you approach a biofire report? So actually, for interpreting whether the organism that is isolated was a colonizer or it is an actual infection, you need to use your clinical acumen. Okay. So if the X-ray is not showing infiltrate, newer infiltrate, if the ventilator requirement is not rising, so it is unlikely to be VAP. So this is a very common practice. Many critical care ICU, they just send one sample for biofire and that picks up all the bacteria that are available in your ICU. And you start treating that, and then you put in colistin, then the patient goes into renal failure, you put the patient on dialysis, and once you put the patient on dialysis, then the patient will later develop a line-related infection. Then you go in for line-related sepsis treatment, patient will go into develop Candida auris infection. So this is a common practice. So avoid all these, avoid sending unnecessary biofire. And the one problem with biofire is that it can pick up dead bacteria. So never use this kind of investigation for following up. So even if your bacteria is dead, biofire will still pick it up and you might end up treating the patient for a long period. You need to know some resistance pattern, but the problem is that always we need to, biofire is something that is, I would say, it is good for start. Interpretation is quite hard. So always don't depend completely on the biofire. Always correlate with your clinical report, with your clinical picture as well as the culture. Other than biofire, we have a lot of, for gram-negative infection nowadays, we do have a lot of other infections. So there is Carba-R, which is nothing but use your gene expert cartridge that you use for tuberculosis. You can just identify the bacteria as well as resistance mechanisms. Identify the resistance mechanism like NDM, OXA48, KPC, using expert Carba, and this will give the result. इंजेक्शन लिया तो जल्दी रिकवरी चांस रहता है, नहीं तो वो टैबलेट खाएगा तो एक 8 से 10 दिन चाहिए रिकवर होने के लिए.
Bloodstream infection. So if you are suspecting a gram-negative bloodstream infection, just send few ml of blood, and within 3 to 5 hours you are going to get whether it is a Pseudomonas, Klebsiella, or E. coli. Only thing is the test is really costly. Sequencing is another method, but everything, whatever problem I have told for biofire applies to sequencing also, because it might pick up dead bacteria, it might pick up colonizers, so all these issues are there. And the upcoming test is Carius test, which detects cell-free DNA, which can be called lovingly as, I would say, liquid biopsy. So coming back to our scenario of brainstem stroke, so rather than the biofire, if you go in for doing a culture of the bronchoalveolar lavage and your report has come like this, so now your report almost everything except colistin, the mepenem, meropenem, so it is a carbapenem resistant enterobacterium. And so the culture, so in a bile culture, so this patient is having fever, so you need to answer the important question whether our organism is a colonizer or whether that's actual infection. So how do you differentiate this? So there are two ways. So if it is a culture and if the Semi-quantitative growth in the culture, the lab will give this report. If it is more than 10 to the power of 4 colony-forming units or 10 more than 10 to the power of 3 if you have used a protected specimen brush, then the infection is likely to be more, it is more likely to be an infection. And if you are using, similarly, if you are using a biofire panel, so the biofire gives values like 10 to the power of 4, 10 to the power of 6, 10 to the power of 8, like that. So if it is having a very high value, like 10 to the power of 7 or 10 to the power of 8, that is more likely to be a pathogen, even though you cannot tell it hard and fast, but still there is a higher likelihood that it is going to be an infection. Always correlate with the clinical syndrome. And there are some organisms which are non-colonizer. Maybe a simple example, in gram-positive, if you take a methicillin-resistant coagulase negative staphylococci, that is more likely to be a colonizer. Similarly, in gram-negative also, if you are getting some exotic organisms, so maybe something like Brevantimonas and all. So these things are more of colonizers, and don't end up reading all these kind of weird names unless it is correlating with your clinical picture. Polymicrobial infection, again, more likely to be colonizers, and always maybe, as I told earlier, you can go in for your trend of procalcitonin, trend of CRP for monitoring the treatment. If a biofire and culture report is showing the same organism, there is a higher likelihood that this might be an infection. So coming to pneumonia in the ICU, gram-negative pneumonia, always there is a possibility that the patient is having aspiration pneumonia. So aspiration pneumonia mostly occurs from hospital flora. So maybe if you are suspecting aspiration pneumonia, maybe this might not work with something like ceftriaxone, because most of the hospital flora is colonized with at least ESBL. You can use biofire panels if it is available. Nebulized antibiotics in pneumonia due to gram-negative infection, they have adjuvant role only. So don't rely on just nebulizing the patient. You might have to give concomitant IV therapy also. And regarding the biofire also, that does not cover all the organism. Maybe some lot of biofire does not cover Stenotrophomonas, Burkholderia, fungal pneumonia, etc. So if your biofire is negative and you are sure that the patient is having pneumonia, maybe you can consider these kind of organisms. Coming to bloodstream infection with gram-negative bacteria, you have rapid diagnostics like the BCL2 panel.
If you will bring
Always do source control, remove the catheters, unnecessary catheters, and if there is an abscess, drain the abscess. Unlike the gram-positive infection, in gram-negative infection, doing repeated cultures to prove that okay, it has become culture negative, this is not commonly indicated. And the treatment duration can be as short as 7 days, as proven in the BALANCE trial that was published in NEJM last year. Bloodstream infection, tigecycline is a poor choice, and avoid as much as colistin and polymyxin B, because there are better. Nowadays, you have better drugs which will be discussed in the further sessions. And if the infection is persisting, even though gram-negative endocarditis is not common, if your cultures are not getting negative or the patient is still keeping on having symptoms, just look for occult focus like infective endocarditis or osteomyelitis. Intra-abdominal infection, unlike the bloodstream infection or pneumonia or urinary tract infection that I have studied, here tigecycline proves to be an excellent drug. And in gram-negative infection, drain culture, what is there in the drain culture is not always infection. That might be again drain colonizer. So you will have to correlate with the clinical picture. And there are conditions like CAPD peritonitis, that's a peritoneal dialysis patient getting peritonitis. You might need intraperitoneal instillation of antibiotic in these kind of cases. Gram-negative meningitis, it is a common problem in the neurosurgery wards because they do put all these EVD, shunt, etc. So, but in gram-negative meningitis is one place so where you will have to give intrathecal antibiotic rather than giving just the IV therapy, except maybe a beta-lactam antibiotic, because they lower the seizure potential. Patient might have intractable seizures. Other than that, if suppose the culture is only sensitive to something like colistin, you will have to give intrathecal colistin, because obviously colistin, the brain penetration is really less. And the treatment duration in gram-negative meningitis also is quite prolonged. It is the IDSA guidelines say that it is 21 days. And gram-negative meningitis, you will have to do repeat CSF cultures to document CSF clearance. And the easiest way for you will be to involve an ID physician. So another scenario, 45-year-old man admitted with body surface burn. Shortly after admission, he developed fevers and blood culture, and culture grew Acinetobacter baumannii. So if you see the culture, if you can see that it is resistant to meropenem, imipenem, but there is a sensitivity to cephalosporin sulbactam. This is a peculiar picture. So what you will do in this case? So as you all know, so the better way will always to call an ID physician. But however, the take-home point from this will be that sulbactam is something that has good activity against Acinetobacter. So if this sulbactam is sensitive, you can always very much use sulbactam as your treatment of choice nowadays. Sulbactam alone also is available. You can give in high doses like 2 gram 8th hourly or 2 gram 6th hourly for Acinetobacter infections. We do have a lot of newer drugs like cefepime, metacobactam, cefepime, cidibactam, cefiderocol, sulbactam, tolobactam, which will be taken up in later classes. So the burning question is colistin same as polymyxin B? So one is a prodrug, one is administered in active form. Colistin is nephrotoxic. Polymyxin B, it is not fully not nephrotoxic. Might be an overstatement. It is less nephrotoxic, I would say. And drug monitoring is easier for polymyxin B. Colistin, where it finds superiority will be in the urinary tract infections. So is colistin totally a bad drug? Because colistin is something that clinicians often get confused. Actually, it is poor in lungs, it is poor in bloodstream infection, but what to do? A lot of time we don't have options, no option other than colistin. Now might be the world might be changed once cefepime cidibactam takes over our Indian markets. But till then, maybe we might resort to colistin considering the cost factors and multiple other factors. It definitely has a very high risk of nephrotoxicity, and it is not alone nephrotoxic, it is highly neurotoxic also. We do see patient initiated on polymyxin B developing a lot of neurologic symptoms like peripheral neuropathy, tingling, numbness, which is goes to intractable levels, and you might have to stop the treatment. And the exact renal clearance, due to rapid renal clearance, we never know colistin when does it achieve the steady state. So overall colistin maybe, so the take home message from this will be that if you are having an alternative agent, always try to use that agent rather than continuing with colistin. So just a few practical dictums regarding drugs. So Pseudomonas, as I told, intrinsically resistant to tigecycline and minocycline. So don't put this new kind of stuff like Astrona Avibactam for all the infection that you are seeing in your ICU. It does not work in carbapenem-resistant Acinetobacter. Colistin works in a lot of infection, but colistin does not work in Burkholderia. Cotrimoxazole, so if it is not working, there are options like cotrimoxazole, minocycline, levofloxacin in some gram-negative bacteria like Burkholderia. These agents work. Cefepime is an agent that does not work in ESBL but works in AMC. And all our future, we all look forward to the drug that is coming maybe by the end of by this month or next month, that is cefepime cidibactam. So I think I will wind up with this, and maybe we will take up questions in the panel discussion. Thank you.
Thank you, Dr. Neetu. Very nice and very clear-cut messages. Actually, that's what I was expecting, and I wanted you to speak something, give a brief of everything, what is more important as you go along, because the basic principles should not be forgotten when you choose these drugs, because many a time we choose a drug which is not effective against that, the intrinsic resistance. So you have to revise again and again so it remains in your mind. So we will have question at the end. So you can put your question in the chat box and we'll take it there. So now let me invite Dr. Vishak. Dr. Vishak C. Carey is a doctor of medicine, ID specialist. He is currently working in USA as assistant professor, division of infectious disease, Wayne State University, Michigan. He has won 40 citations of his lot of papers, H index about 8, multiple publications, peer review for leading journals, editor Frontier in Pediatrics, and he's got a lot of grants for his work. ITSA Travel Grant Award, Best Oral and Poster Award in Michigan and USA Conference 2023, National Abstract winner, American College of Physicians. He's a member of all these societies related to infections, the Infections Society of America, Physician Michigan Infectious Disease Society, Diagnosis Study Group. His main area of interest is immunocompromised host, HIV, transplant, infectious disease, antimicrobial stewardship, and communication. So he is going to talk on a very important first mechanism which we are going to discuss. There are ways that we are discuss. So he's going to talk on the MC and ESPN. What is the mechanism? How do you detect it? And how you manage this? So over to Dr. Vishal. And thank you very much for joining.
Thank you, Dr. Chawla. Let me share my screen. I think are my slides visible?
Yes, just put a slideshow.
Yes.
No, it is not slideshow. Yes.
Yeah. Okay. Thank you very much, Dr. Chawla, for that very kind introduction. And thank you, Dr. Neto, for setting the stage wonderfully and explaining the landscape of antimicrobial resistance. And that gives me an opportunity to dwell deeper into speaking about extended spectrum beta lactamases and AMC using enterobacter. So through my presentation today, the goal of my presentation today will be to break your trust. So when I say break your trust, not to break your trust in me, but to break your trust in that sensitivity report that you will see an antibiotic to be susceptible, but you will second guess yourself whether you're going to use it or not from all that you will try to learn from this module. So having said that, let's move on to see what is the scale of this problem, right? Over 1 million deaths are attributable to antimicrobial resistance globally, and over 50% of the E. coli isolates in Indian tertiary care hospitals are already ESBL positive. The mortality rate, 30-day mortality rate, reaches up to 40% with ESBL bloodstream infections, and these AMC producers, they have 20% chance of causing depression while on therapy and become resistant to circulation cephalosporins. The problem is huge. So let's start to understand by the basic mechanism here. So when this is the gram-negative cell, basically, and your beta-lactam antibiotics basically are pumped into the periplasmic space. And when they move into the periplasmic space, they bind to penicillin binding proteins and kind of disrupt the formation of the cell wall. So to counteract these antibiotics, bacteria have amazing mechanisms which are production of enzymes called beta-lactamases. Now these beta-lactamases could be enzymes which could be encoded from plasmids, or they could be from the chromosome as well, chromosomal AMCs in general. So what they do is kind of cleave the beta-lactam ring, cause the hydrolysis of it, and then cause resistance. So when I talk about beta-lactamases, just to put things into context and to build a concept of ESBL and AMCs, you can see that the beta-lactamase spectrum for a particular antibiotic can range from penicillins to carbaphinamases, and accordingly they are called penicillinases and carbaphinamases. So in between this entire spectrum are your narrow spectrum beta-lactamases, extended spectrum beta-lactamases, and AMC producers. And this chart kind of gives you a sense of understanding as to how much is the spectrum of extended spectrum beta-lactamases going up to knocking off all your cephalosporins and aztreonam, and really the only ones which become susceptible are carbaphinins or cefamycins, which we really do not use much clinically, but it's kind of a lab thing something that you can use. And AMC producers, as you can see, again, the cephalosporins are knocked out, except for cefepime, which I will be talking about later. But just to kind of put things into context, how the spectrum of beta-lactamase extends from penicillinases to carbapenemases, and it is not just extended spectrum beta-lactamases or AMC. So with that building block, we'll first start to talk about extended spectrum beta-lactamases and their management. Okay. So what are these extended spectrum beta-lactamases? So these are usually enzymes which are plasmid-borne. So because they are plasmid-borne, they can be transmitted very easily horizontally across the species and other bacteria. Are you gonna use cefepime? Are you gonna de-escalate to ceftriaxone? It is sensitive. Are you going to de-escalate to ceftriaxone? Or are you going to continue piperacillin? So the answer to this question is cefepime. So you're going to use cefepime. So the reason being is, and I will talk more about it in the next slide, amongst the cephalosporins, and of course the answer, if you did meropenem, you're never wrong, you did that, but it's not really a stewardship failure. And amongst the cephalosporins, a lot of the cephalosporins, cefepime is one of the antibiotics you can use if you have an MIC. You look at the cefepime, you look at its MIC, and if it's less than 2, you can kind of use, and it's appropriate. You do not want to de-escalate to ceftriaxone. You know it's a third generation. It can, you know it is an inducible AMC producer. You can't shift to peptazo because again it can get hydrolyzed as well. And this is the table that I want you to kind of look at and kind of understand. Any antibiotic that you're going to choose for an AMC producer, you have to ask 2 questions, right? Whether this antibiotics can induce my AMC, whether it's a strong inducer of AMC or a weak inducer of AMC, and how good a substrate it is for lysis. Is it a good substrate that will get lysed, or is it a poor substrate? And if you look at the bottom corner here, the antibiotic that wins amongst all of the other antibiotics is your cefepime, which is both a weak inducer. It's not going to induce AMC as well as other piperacillin, other generations, or other cephalosporins, and even it is a poor substrate. It's not going to get hydrolyzed very easily. So if you want to use one antibiotic and save your carbapenems, it is going to be probably a cefepime, but in the right clinical context. And definitely you can use non-beta-lactam antibiotics. And the principles of that effect are similar to what medicine costly extended spectrum beta-lactam. Injection ಹಾಕಿದ್ರೆ ಅದು 3-4 100 ಇದು ಅದುಗೆ substitute. Okay, so you definitely can use cefepime. Look at the MIC. That's the first clinical teaching point. Okay, second clinical teaching point. You have a 72-year-old woman, diabetic CKD, post ERCP, developed cholangitis, has a biliary stent, has developed multiloculated liver abscesses. You can't drain all of these. You drained one of them, and you took blood and drain fluid, and it's growing Enterobacter flow. Okay, we already spoke about Enterobacter flow. Okay, it's one of the moderate dire inducible AMC with high risk of induction. Right? You look at the day 0 susceptibilities, expected. Ceftriaxone is going to be sensitive. You look at cefepime MIC, excellent. As we spoke about it, it's doing great. MIC of 1, right? And you look at other antibiotics as well, meropenem and stuff like that. It's kind of susceptible. From what I already taught you, you chose cefepime. MIC is doing great. Poor inducer, poor substrate, excellent. But then on day 5, there was no improvement. Patient is still febrile, bacteremic, ecloquy persists, and there is some brain output. And you look at cefepime on this, now it's become resistant. What went wrong here? Or what was wrong in our cognitive, in our thinking process? On day 0, if you looked at multiloculated abscess, incomplete drainage, even if you had a cefepime MIC of 1, I want you to pick a carbapenem, and that will be the answer to this because of what is called as inoculum effect. In high inoculums, it is said that, and if you do not have a good source control, cefepime at standard inoculum might be good, has 6.5% failure rates. Then With high inoculum, the failure rates goes up to 54.8% and MC producing and tobacco rate even higher at 61%. So the take-home point that I wanted to kind of drive through this is look at your cefepime MIC. Okay, look if there is a push control also achieved or not. Otherwise, do not use cefepime. Use cefepime. Otherwise, go to meropenem. Okay. Now, so next teaching point to another case that I wanted to bring up is you have a 65-year-old male. He's tracheostomy dependent, mechanically ventilated on ICU day. He starts developing fever, patients, opacities. Definitely, you're thinking of a ventilator-associated pneumonia here. You take the tracheal aspirate here, and it is drawing cleverogenins, and yeah, it's an AMC producer. It is an AMC producer, and when I said an AMC producer, first antibiotic that you look at is cefepime. When you look at its cefepime, MIC is not less than 2. It is around 4. Okay. So now, and you look at cefoxitin, I kind of told about that as well, and you saw ceftriaxone, which is resistant, and you're like, yeah, could be having an ESBL, but I look at cefoxitin, and I'm like, oh, that's resistant. Probably it's just an AMC user, truly just an AMC user. Can I just go ahead and do cefepime, right? And that's where the mistake happens. These organisms can have co-production, and the cefepime MIC, higher MIC is a clue here. If the organism just had an AMC with no ESBL, the cefepime MIC are typically low, less than 2. That's why I say look at cefepime, look at the MIC, make sure it's less than 2. If it is more and it's going in a higher range, 4 to 8 and 16, and it's going at a higher range, you're probably thinking of an ESBL co-production. And studies have shown that approximately 20% of your AMC producers can have ESBL co-production. So look at that cefepime MIC. If it is high, treat it like an ESBL also, like a co-production. Okay? The 3 clinical rules for the management of AMC rate. We'll open it up for the end of discussion.
Thank you, Dr. Vishak, for giving a detailed presentation, although quite technical at many points. All kind of people who have joined. So don't worry if you've not understood. We're going to repeat all this as we go along the approach to gram-negative infections. So we'll have some of the questions now, just to simplify these stuff. So I'll ask first Dr. Nedu. When should we suspect a carbapenem-resistant organism upfront, even before the culture reports are available? And how does that suspicion change your empiric coverage?
Yeah, so that's a good question. So, whatever the risk factors for acquiring a multi-drug resistant gram-negative infection, so probably presumes to be carbapenem resistant infection. So if the patient is having a history of prior colonization with a carbapenem resistant organism, if recently in the last 90 days they had history of hospitalization, because if you see the overall Indian statistics, it would be like if you see overall the urinary tract infection, maybe around 50 to 60% of them as per the ICMR data are ESBLs, and maybe somewhere over 20% of them are again carbapenem resistant. Okay, so especially with respect to the in-hospital sample. So coming to the, if it is a ventilator-associated pneumonia sample, if your patient is having developing ventilator-associated pneumonia, so these are the situation where you always have to go by the hospital antibiogram. Unfortunately, a lot of our hospitals in India are not generating their own antibiogram. For whoever generates, that would be very good. But if you take the overall profile, actually it would be something like Acinetobacter and Klebsiella that is leading the show. So, and most of these are carbapenem resistant. So, if the patient is in such an ICU, a tertiary care hospital ICU, with a lot of carbapenem resistant organisms teeming around, obviously your empiric choice also would be something targeting that. So it also adds up to your infection control practices. So as you know, Acinetobacter is something that is rightly from the dry surfaces. So if your surface cleaning is proper,
the chance of acquiring Acinetobacter from the hospital is really less, but whereas other organisms like Pseudomonas are acquired from wet surfaces that can come from everywhere. So considering all these, so empiric treatments to be started for gram-negative carbapenem resistant organisms. It depends primarily on your hospital flora, hospital antibiogram, comorbidities, the recent hospital admission history, recent colonization of the patient with any multi-resistant gram-negative organism. So these are some common factors, and that will guide your empiric antibiotic therapy.
Just for my knowledge sake, Dr. Shah, MRI which what is the common organism?
Brain So, I mean, in the US in general, if I have to talk about it, there's a lot of gram positive organisms that we deal with, and gram negative resistance is not a huge problem in general in most of the US kind of ICUs. But specifically where I work at Detroit Medical Center, we get a lot of patients from long-term LTACs and long-term acute care facilities and nursing homes and stuff like that who have been exposed to a lot of antibiotics, prior exposure to antibiotics, and we do see a lot of resistance as well. And while it was just limited to kind of ESBLs and stuff like that, we are beginning to see a lot of targeted as well, which was limited to, again, KPCs, but our Michigan data is kind of showing that in ICUs now we are also dealing with NDM infections, and we do use a lot of newer BLBLI combination therapies, especially in one of the hospitals, which kind of caters to this kind of population.
So, this is very important that whenever you choose, it differs. You have to know your hospital, your community, and even in the same hospital, different ICU may have. So, because when you choose empirically, that's extremely important when you consider choose an empirical. So, the blood supply what is the practical role of rapid molecular diagnostics in blood culture, identity panels, changing the management of gram-negative. You've talked about it, but
Practically, you can take it in two ways. So most of the common one is the biofile BCAD2 panel, that's the blood culture identification panel. So how it works is that you take the blood culture and this culture has to grow the organism. Once the growth starts and once this beeps, once the culture bottle beeps, from that you can send this sample, you can apply this sample for BCAD2. For BCAD2, and that will give you an idea what is the organism that is present in the blood culture, and at the same time it will give some resistance mechanism. So that is one way to approach that. So maybe if you ask me, it will be apparently equivalent to the time taken for the organism to just show its first growth in the blood culture. So maybe it would be less than 24 hours, maybe if not 10 to 12 hours. Yeah. But if you go by the conventional method, it is like first the growth comes and then you have to subculture, then the subculture has to grow, and once the growth comes in the subculture, then you go in for the antibiotic susceptibility testing. So anyway, you are going to get a lead time of 48 to 72 hours if you are using this. But practically there is another way to it, because what we would be comfortable is the patient coming with a sepsis, you just do a blood test and you are going to get the organism. So that's what most of us are practically looking at. So it is like there are assays like the Sentifast, checker and all. So you just send the blood, but a lot of time the sensitivity of these tests are not up to, maybe not up to the BCAD2 panel, I would say. Even the specificity also, it is like that, because there are a lot of issues with this kind of sample setting. Maybe something that we would look forward is the Carius test that I was mentioning. Maybe you just send the blood, and this blood, you just send the blood, and it is like a liquid biopsy, that's a cell-free DNA you are obtaining from that, and that will just denote the name of the organism. Maybe if you ask me which test is somewhat close to this, is the T2 bacteria assay, which is again not available in most of our hospitals. So T2 bacteria assay mainly for gram negatives. It has Acinetobacter, it is Klebsiella, it is E. coli as well as Pseudomonas. So if these organisms are present, you just if you are suspecting a sepsis, just send the blood. In 3 hours you are going to get the result, but the result only says that whether this is a Klebsiella or Acinetobacter, but it does not give you the resistance pattern. In a nutshell, BCID2 gives you resistance pattern as well as name of organism. Septifast, you can directly send it from the blood, but the sensitivity is much lower. T2 Candida assay, T2 bacteria assay, really good, but just gets the name of the organism and plating. You will have to go your flora. And carriers test, practically I don't have experience with carriers test. Yeah.
The Septifast, which
ನೀವು ಒಂದು 10 acres ಕೊಟ್ಬಿಟ್ಟು 40 acres ಹೋದ್ರೆ
Absolutely, absolutely. So that's why Septifast one is
we should just wait till we should spend the money on different stuff for the patients. Gets infection.
ಒಂದ್ ದಿವಸ
ಅಪ್ಪ ಆಕ್ಸಿಡೆಂಟ್ ಆಯ್ತು. And you start the empirical activities.
ಹೆಡ್ ಇಂಜರಿ ಆಗಿದ್ರಂತೇನು ಆ ಟೈಮ್ ಜಗಳ ಮಾಡ್ತಾ ಇತ್ತು.
And what are the most common barriers to encounter clinically in India?
ಆ ಟೈಮ್ ಲಕ್ಷ್ಮಣ ಅಂಕಲ್ಗೆ ಮೀಟ್ ಆಗಿದ್ದಾರೆ ಆ ಕ್ಲಿನಿಕ್ ದಲ್ಲಿ 2-3 ಅವರ್ ಜನ ಮಾತಾಡ್ತಾರೆ.
Really big challenge. Maybe I would say that Dr. Vishal might be in a very comfortable position with respect to de-escalation because in US you get a lot of levofloxacin, quinolone susceptibility, you get cortisone susceptibility. But in India, hardly we don't have, I would say that practically we don't have anything. Except maybe if it is a multi-drug resistant gram negative, maybe the only practical option might be to give tablet minocycline. That is something that we could do. So even if we want to de-escalate as part of antibiotics stewardship, but the only drug that is available for us is multi-drug resistant organism. That is going to be minocycline. For Pseudomonas, again, hardly maybe in Europe scenario in Indian ICUs, if you see the sensitivity of quinolone, it is somewhere near 10 to 12%. And the new drug also, that also, that will work only if levofloxacin is sensitive. So that's how it works. It is not for the resistant part. It works in MRC, but it is not under the marks. Practically we don't have, but lot of times, especially in organism like bacteria, stenotomus. So these kind of stuff maybe we do get levoflox sensitivity, we do get cortisone sensitivity. So this is somewhere where even though the treatment duration is long, where we come down on the oral antibiotic. Looking forward to the new FDA that is tebipenem. So maybe once it comes, at least maybe our ESBL options might be solved.
50 acre ನಾನು ಒಂದು ಪೈ ಕೂಡ ಇಲ್ಲ ಯಾರಿಗೆ ತಾತ ಪರ್ಚೇಸ್ ಮಾಡಿದ್ದಾರೆ ಅದು ಮುಂಚೆ ಇತ್ತು ಅದು ಅದನ್ನು
I just want
ಏನು ಹೆಸರು ಅಮರ್ ವಯಸ್ಸು 34
I'll ask Dr. Vishak. So
ಅದಕ್ಕೋಸ್ಕರ ನಾನು ಊರು ಹೋಗಿಲ್ಲ ನನಗೆ ಪೀಸ್ಫುಲ್ ಲೈಫ್ ಬೇಕು ರೆಂಟ್ ಬರುತ್ತೆ ಅಪ್ಪ ಅದು ರಿಟೈರ್ಮೆಂಟ್ ಸ್ಯಾಲರಿ ಬರುತ್ತೆ ಅಪ್ಪ ಆರ್ಮಿದಲ್ಲಿ ಇತ್ತು
Yeah, I mean, when you're telling ESBL detected, I think what you're referring to is like a genotypic test. If I can, is what I think.
So around 60-70 retirement pension
comes as ESBL detected. So we do have a blood culture system which is very clean system. When the blood culture lacks, it kind of gives us the organism, also says the resistant marker. So it says that CRCCID is detected. But again, these assays kind of have their own limitation as to the number of genes that they can detect in general. So fine, CDXM is detected excellent, but if it's not a CDXM and some other kind of chemical gene which is being producing, this assay might have limitation which might not be able to pick it up. So what I would say is second thing, they might not work well in polymicrobial infections because in polymicrobial infections might be picked up in E. coli, but that's coming from or something that's not kind of detected by the very gene or stuff
ಈಗ
like
ಒಂದು
that.
ತಗೊಳ್ಳಿ,
So
ಬೇಕಂತ ನಾಳೆ ತಗೊಳ್ಳಿ, ಇಲ್ಲ ಅಂದ್ರೆ
polymicrobial
ಬೇಡ.
infections, they do not really
ಇದು ಒಂದು
do very
gastric
well.
ಮಾತ್ರ.
And in such cases, I would say that
ದಿನ ಬೆಳಿಗ್ಗೆ
go
ಊಟ
ahead and
ಮುಂಚೆ.
rely on your
ಇದು ಈಗ ಒಂದೊಂದು ತಗೊಳ್ಳಿ,
susceptibility.
ಮೂರ್ನು.
But if a very
ಆಮೇಲೆ
gene report
ಬೇಕಂತ
tells me
ನಾಳೆ ಒಂದು ತಗೊಳ್ಳಿ, ಇಲ್ಲ ಅಂದ್ರೆ ಬೇಡ.
genotypic
ಬರೀ
susceptibility
ಎರಡು
tells
ಈಗ
me
ನಾಳೆ
for
ಬರ್ತೀನಿ.
sure in ESBL detected,
ಚೆನ್ನಾಗಿ ನೀರು ಕುಡಿ, ಯೋಚನೆ
I
ಮಾಡಬೇಡ.
would escalate the antibiotics and I would treat it as an ESBL unless my phenotypic susceptibilities tell something else, which has
ಇದು
happened
ಬೆಳಿಗ್ಗೆ
very
ರಾತ್ರಿ
rarely.
ಊಟ
And
ಆಮೇಲೆ
if you can kind
ಊಟ
of
ಆದ್ಮೇಲೆ ಊಟ ಆಮೇಲೆ ಬೆಳಿಗ್ಗೆ ರಾತ್ರಿ ಊಟಕ್ಕೆ ಮುಂಚೆ.
Dr. Bishop,
ಇದು ಬೆಳಿಗ್ಗೆ ಮಧ್ಯಾಹ್ನ ರಾತ್ರಿ ಊಟ ಆದ್ಮೇಲೆ. ಬೆಳಿಗ್ಗೆ ಮಧ್ಯಾಹ್ನ ರಾತ್ರಿ ಇದು ಮೂರು ಸರಿ ಊಟ ಆಮೇಲೆ, ಇದು 2 ಸರಿ ಊಟ ಆಮೇಲೆ, ಇದು 2 ಸರಿ ಊಟ. ಸರಿ, ಇದು ಟ್ಯಾಬ್ಲೆಟ್.
The other thing is that
ಏನು
carbapenem has traditionally been the cornerstone of ESBL. And is that being challenged now? What is the current evidence for carbapenem sparing strategies? We talked about.
Yeah, of course. I mean, carbapenem is not always the answer for extended spectrum beta lactamase enterobacterials. There's a lot of evidence that you can. I mean, when you talk about beta lactamase as a mechanism, it can act on beta lactams. All other non-beta lactam antibiotics are kind of spared from it. But as I kind of told, it is plasmid borne, so you might have to, and especially in high endemic countries where ESBLs are very high, they are on baseline use of the oral medications like fluoroquinolones, Bactrim, and it is so high and unregulated. These organisms can kind of have baseline resistance, and that's what Dr. Neto was kind of pointing towards, that we might not have oral options. It's not about lack of evidence, it's lack of, I think, lack of availability of the susceptibility which will allow you to kind of use them. So of course, if you have the right syndrome and you do have susceptibilities available, there is extensive data which says that you can go to fluoroquinolones, Bactrim, nitrofurantoin in the right setting of, you do not have to burn a carbapenem on a cystitis. You can get away with nitrofurantoin, right, if it is kind of susceptible. And aminoglycoside susceptibilities, you can get away with that if you can preserve the renal function and stuff like that. So definitely there is a lot of literature coming up with using non-beta lactam antibiotics. Really, I think the problem there will be availability, the susceptibility pattern which we will deal with, and we might not have options to use it, but not limited by data in general is what I would think.
So I'll just ask the last question. So what is the role of piperacillin tazobactam, with the Merino trial, and should we use it or should we not use it? There is no role of this now after this.
I mean, the thing about piperacillin tazobactam is people kept realizing that there was some mechanistic issue with this antibiotic, right? So piperacillin tazobactam, when they saw at a standard inoculum, and when you test it in the lab, you're testing it at an inoculum of 10 raised to the power of 5, right? So when you're testing at that inoculum, it's probably telling that your antibiotic is susceptible, but it does not translate into in vivo setting where there could be high burden, high inoculum kind of a setting where piperacillin tazobactam might not work to reach that particular MIC levels, and kind of whatever standard dosing that you're doing might not overcome it. That is the first thing. Second mechanistic problem that they kind of saw was the tazobactam component. It is like a suicide inhibitor in contrast to other beta lactamase inhibitors like avibactam and stuff like that. What happens is that it does not neutralize your beta lactamase, but in general it gets consumed by this by the beta lactam. And by that, what I mean is, even before it is able to inactivate it, the tazobactam is getting consumed by so much amount of bacteria that's producing beta lactamase in general. So the piperacillin is just let alone to kind of be degraded. And the third also is, like, when you look at the ratio of piperacillin tazobactam, it's almost like 8:1 kind of the dosing, the ratio in which it is made compared to like ceftazidime, avibactam and stuff like that, where the ratio is like 2:1. So what I was trying to get at is the ratio also is kind of very high. The tazobactam amount is very low. So with these mechanistic concerns, that is when they kind of said that, yeah, we need to do a head-to-head trial, see if it can be used or not. And Merino trial kind of settled this debate forever and overall, that I would now be comfortable using piperacillin tazobactam even if you show me a report which is susceptible. I would use a of course, meropenem or a non-beta-lactam antibiotic medication is important.
Thank you, Dr. Vishal. With that, I would like to thank Dr. Neetu for taking a wonderful lecture and Dr. Vishak for taking us through the mechanism and the ESBL and MC and how to go about and showing some cases. So thank you very much. And Dr. Akansha for wonderfully recapping. You make the thing simpler of the last lecture for all the audience. Thank you very much, Lexicon IT team, for conducting this, Design Biosciences for supporting, and all the audience, more than 1,000 people who are sitting there. Thank you so much for joining us in large numbers, and which is stimulating us quite a bit. Thank you very much. Have a good night. Thank you.
Thank you, everyone.
Thank you for joining. Thank you.